morning, everyone. I'm Dr. Musheer Ahmed. I'm a general surgeon by profession. I'll be talking on a case that we have recently operated and is being presented as a hypothalamic injury following surgery for a craniopharyngioma case, which resulted in a post-operative death. Introduction. Craniopharyngiomas usually represent 2.5 to 4% of all intracranial tumors. Their incidence is 0.5 to 2 cases per million per year, and they're slightly more common among children, where they represent roughly 50% of the cellular and supracellular tumors. These have a bimodal distribution of age at diagnosis, the first being 5 to 10 years of age, and the second spike being 50 to 65 years of age. Craniopharyngiomas are benign cellular supracellular tumors derived from the embryonic tissue. Even though these tumors are slow growing and benign, they cause complications as a result of mass effect on the neighboring structures. This results in the patient presenting with symptoms such as headaches, bitemporal hemianopia, and hypopituitarism. Coming to the pathology, grossly, these tumors contain solid and cystic components, with the most of them having some amounts of calcification. On histology, these tumors are classified as adamantinomatous or papillary. The adamantinomatous type is more common in children and is characterized by palisading columnar cells that resemble ameloblasts, whereas the papillary type are more common in the 50 to 65-year spike age. Points to be noted. Radical excision of the large multi-compartmental craniopharyngiomas usually leads to injury in the hypothalamus. However, complications arising from autonomic dysfunction, which was seen in our case, are usually uncommon and do not respond well to the treatment. Our case was that of a 13-year-old child that was admitted with a history of headache, which was of pain band type. He had projectile vomit and had associated seizure of GPCS type. Neurological examination was largely unremarkable with no sensory or motor deficits preoperatively. There was, however, bilateral papilloedema seen. Investigation done was that of an MRI, which was with gadolinium enhancement, which revealed that the tumor was multi-compartmental, extending from the supracellular cistern to the left and invading the prepontine cistern on the left CP angle, causing effacement of it. And this resulted in the mass effect on the left side brainstem. It also was loosely adherent to the basilar artery. These are the MRI fields. This is a coronal section of the MRI showing the heterogeneous enhancing lesion in the cellular and supracellular region. This is a sagittal view. It is a contrast enhanced MRI showing the solid and cystic nature of the cellular lesion. The solid lesion was in the anterior aspect, which is greatly enhanced, whereas the non-enhancing cystic lesion on the posterior aspect of this lesion. And we can also see clearly that there is there's a supracellular extension of this tumor. The axial cuts of the MRI shows that the solid lesion, as is centered, is going on towards the on the left CP angles cistern. What is also seen over here is that the basilar artery is loosely adherent to the lesion. Coming to the treatment proper, under the cover of the antibiotics, anti-epileptics, mannitol, and a left diurnal craniotomy was done. A trans-Sylvian approach was taken. The arachnoid matter was opened, and a left internal carotid artery and optic nerve were identified. Then, going via the optico-carotid cistern, gross total resection of the tumor was performed with sufficiently safe margins so as to avoid the risk of recurrence. Except for the hypothalamus, there was a good cleavage plane between the surrounding neuronal and vascular structures and the tumor. Immediate post-op status revealed that the entire operative procedure was uneventful. The patient was hemodynamically stable with a normal sensorium immediately after the surgery. The only abnormality noticed was that of a right lateral rectus weakness, which was concomitant with subtle right pyramidal weakness. These are the intraoperative pictures. The first picture is that of a left diurnal craniotomy showing the burr holes with the craniotome. The bone flap is seen clearly. The second picture shows the on-table photo under the microscope, which shows the opticocarotid system. As can be seen, this is a left optic nerve. This is the left internal carotid artery. This is the left anterior carotid artery, and this is the left posterior communicating artery. The tumor is seen in the opticocarotid system. Clearer, more visual aspect of the tumor. As can be seen, the excision of the tumor is done while applying traction to the surrounding structures. Finally, after excision of the entire lesion, the wound was closed with first closing of the dura using 504 and then using titanium mini plate screw system, the bone flap was replaced, and finally the muscle and skin sutures were placed with a drain. Post-operative CT was done on post-op day 0 itself in the evening time. The axial cuts, the coronal sections of this contrast-enhanced CT are seen. It shows that there's no residual tumor left after the excision was taken place. Some amount of edema is surely seen. Coming to the post-op complications, on the 5th post-op day, the patient developed diabetes insipidus with a serum sodium concentration of 165 milliequivalent per liter and an increased urine output of approximately 2.5 to 3 liters per day. He was treated with desmopressin spray and intravenous fluids were given. On the evening of post-op day 7, the patient started developing hypothermia with a temperature of 33 degrees Celsius that was noted. Patient also showed symptoms of shivering. ABG analysis were done frequently and was found to be normal throughout. The next morning, he was found to be with a GCS of 7, which required immediate intubation and ventilation. The next day, the patient developed wide blood pressure fluctuations. An echocardiogram was done and identified a left ventricular dysfunction. Soon after this, the patient succumbed to fatal cardiac arrest despite all resuscitative measures that were taken. Coming to the discussion point of the presentation. Despite all of the recent advances in operative techniques and surgical equipment, craniopharyngioma is considered difficult to treat. The optimum treatment strategy for it remains ambiguous up to now. The gross total resection, as was done in our case, is considered to be the gold standard. However, the approach can be challenging due to the location of these tumors, which is usually in the close approximation with structures such as the optic chiasma, the hypothalamus, and the internal carotid arteries. A more conservative approach is that of a subtotal resection with a subsequent radiotherapy, which consists of deliberately leaving around 10% of the residual tumor. This approach has been shown to have a reduced surgical complication rate, but there are a higher chance of the tumor recurrence and adverse effects from radiation that can be faced. Post-operative morbidity due to gross total resection commonly encompasses endocrinopathies, leading to a pan-hypopituitarism state. However, death as a result of hypothalamic damage is rarely reported. Coming to the inferences drawn, based on the clinical characteristics of the patient, it can be hypothesized that the following areas of the hypothalamus were damaged: the supraoptic and paraventricular nuclei, resulting in diabetes insipidus, as well as the posterior hypothalamus, the ventromedial, lateral, the paraventricular, anterior nuclei, resulting in hypothermia, tachycardia, and wide fluctuations in the blood pressure. The cardiac dysfunction, which was a result of the injury to the autonomic region of the hypothalamus, ultimately led into ventricular failure and eventually death. It is our belief that our attempt at gross total resection proved to be fatal due to the damage of the multiple hypothalamic nuclei as mentioned above. This injury to the hypothalamus may have been most likely a result of vasospasm due to the handling of vessels that supply the hypothalamus. A less radical approach that could have been done, such as that of a subtotal resection with subsequent radiotherapy, would have probably avoided the patient's mortality, especially when we noticed multiple hypothalamic nuclei adherent to the surface of the tumor. This is further substantiated by a systemic review done by Young et al. That showed that the subtotal resection followed by a radiotherapy was an acceptable approach to achieve tumor control while limiting hypothalamic morbidity associated with gross total resection. Conclusion. Gross total resection is considered to be the gold standard treatment for craniopharyngioma and is successful in most of the cases as it hinders the chances for recurrence of the tumor. However, in our case, the tumor was noted to be multi-compartmental and was adherent to multiple nuclei of the hypothalamus. The use of gross total resection in such circumstances led to the damage of various nuclei of the hypothalamus, resulting in deterioration of the patient's health and finally led to his demise. There are two important learning points that can be taken from our case. The first being that the undue traction to the hypothalamus, as well as the perforator supplying it, has to be avoided if gross total resection has to be attempted in cases such as ours. The second point, in cases such as ours, the idea of subtotal resection followed by a subsequent radiotherapy may prove to be a better approach, despite having a higher recurrence rate because the life-threatening extreme damage to the hypothalamic nuclei could have been avoided. Here are some of the references that I've used. Thank you.